Good afternoon, everybody. Welcome to another great session by the New York chapter. And today our featured speaker, once again, is Helen Oscislawski, who will talk about information blocking as it applies to the CARE Act. Helen, thank you very much for joining us again today. And let me turn it over to you and get the presentation started. Thank you.
Thank you. Thank you to the New York chapter of HIMSS for inviting me back for this update on information blocking, and to Nick and Anthony for again inviting me for this presentation. I am going to jump right in with sharing my screen. Okay. There we go. Okay, so as Tony mentioned, I'm going to do an update. I think some of you maybe have joined me for prior presentations on this. There will be a little bit of a review of the components of the information blocking rule. But as many of you are aware now, a number of months have gone by since we first looked at this, and so I'll be focusing a bit on the burning issues. I've been working closely with a number of types of clients who've been drilling down and trying to figure out exactly how to implement this stuff. And so we'll take a look at that and see if we can glean some insight into those hot topics and the burning issues with implementation of information blocking. So just to review the deadline dates, okay? On the top portion, this chart probably is familiar to many of you. It's directly from the ONC's website that promulgated not only the rule for information blocking, but also is overseeing the certification piece. So I'm going to presume the majority of you, although there may be some of you out there that actually are on the vendor side. The top piece, you'll see you have your own timeline, obviously, for that certification, which coincides with some of the more practical pieces that healthcare organizations, healthcare providers, HIE, HINs are looking to implement. So the bottom piece is what I'm focusing on today. And you can see that bottom piece talks about actual compliance with the information blocking provisions. And what does that mean? That means that once the deadline goes past, if somebody requests access to electronic health information as that is defined, you have to think twice before saying no, because now you may be engaged in impermissible blocking of electronic health information. Of course, the policy and the drive here is to prevent organizations from unnecessarily attempting to block information or to not allow the free flow of information. The federal government's really looking with some emphasis on patients getting access to and being able to control their own information as definitely a focus area, but also to prevent and to eliminate some of that, I would say negative competition that has resulted in some vendors and some organizations to resist sharing information for reasons that are, in the government's views, not conducive to things that promote healthcare quality. And so you can see on the bottom here that the deadline has passed. That means once the rule was passed, April 5th, 2000 of this year, so just a few months ago, all of the information blocking requirements have gone into effect. Now, there is a delay in terms of the scope of information that you are obligated to respond with. It doesn't include the whole entire world of all data that you have. From April 5th of this year through October of next year, if you're asked for certain electronic health information, you are only required to comply or to respond with what's called the US CDI data set. And I'm going to go into towards maybe the middle or so of the presentation, because we just had the version 2 that went into effect last month in July. And I'll highlight some of the changes and the differences between version 1 and version 2 with regard to the differences there in terms of what you need to comply with. On the right-hand side, you can see that once October of next year passes, it's open season for all EHI. And open season, I mean that anybody that asks, or any organization that asks, whether it's a researcher, whether it's a health plan, whether it's an individual, whether whoever it is, if they request electronic health information or access to it, you know, your first reaction is I likely will need to give that to them unless I can justify a basis upon which, or an exception, as we're going to go through again and review, an exception upon which I can refuse to give access to that EHI or a copy of that EHI to that requester. So it kind of turns HIPAA on its head. I always say that we used to be like, we're not giving anything because HIPAA, you know, the privacy protections, confidentiality protections, and organizations felt comfortable and took a baseline approach of not sharing information. And as you can see, this new regulation turns the entire position on its head. So when you are faced with a request for electronic health information, you can no longer just say HIPAA or whatever as a basis to say I don't want to share. You have to say, okay, the information blocking rule requires me to share this information. Is there a legal reason or a basis upon which I am accepted, or I am safe from not sharing this information and not to be found violating the rule? And so that's what many organizations are struggling with. So the top, you know, again, we've been at this for a couple months now. I've worked with numerous hospitals at this point, healthcare systems, member organizations. I've worked with a number of member organizations that were FQHCs, HIEs, HINs, and, you know, there's been a couple of repeated theme issues that have come up over these, as you know, as those organizations started to focus on, like, what do we need to do here to comply? You know, they took a look, and some of these issues that came up. So first is whether or not I'm an actor that has to comply with this rule. Just believe it or not, not all actors and not all kinds of organizations need to comply with this rule. And I want to just re-review some of those definitions. By way of example, many government organizations are exempt. They don't fit the definition of a healthcare provider. They don't fit the definition of HIE, HIN, with a few exceptions that I have looked at for a couple of organizations, and then they don't fit the definition of a certified health IT vendor. And so there's been, in some cases, it's frustrating because organizations would like to benefit from certain electronic health data that the government agencies have, whether it's Department of Health, Department of Social Services, or whatever. And they were looking forward to possibly using this rule as some more leverage to gain access to the information, and it's just not the case. Other organizations like collaboratives and things like that, whether or not you meet the definition of actor, again, I want to just review some of those definitions and give you some examples of what I've come across where organizations have decided and determined, oh wait, we're not an actor, we don't have to comply with this, or oh my gosh, we do have to comply with this. Another top issue is simply, does this actually constitute information blocking? So I'll go through a few examples, excuse me, examples I've come across to highlight for you some of the questions or some of the practices that were most common in organizations asking whether they're information blocking. Another top IBR issue, and so when I refer to IBR, it's an acronym. If you have not already heard that tossed around a bit, it's the most common abbreviation used to refer to information blocking rule, which is kind of unfortunate because sometimes I even misspeak. For those of you in the research sector, you know, of course, we talk a lot about IRB approval, and so that's a bit confusing. But anyway, so if you hear me referring to IBR, it's information blocking rule. Number 3 issue in IBR is, do I have to push all that data to a patient portal? And it was a big period of time, I would say a good block of at least a month to almost 2 months where people were really trying to figure out whether they got to push all this data into their patient portal, until finally ONC published a number of FAQs and questions and guidance on that, which to some extent clarified it, and to other extent left open still some interpretation and confusion on that. So I'll review that. Number 4, can we delay lab results in order to prevent harm or for other reasons? Very, very common practice in many organizations, and created a bit of a uprising, if you will, because it was a common practice to delay lab results for a number of reasons as a matter of course. And again, the interpretation by ONC of the rule and how it works really disrupted that. And so I'll go through it and let you know how a number of organizations have attacked that and addressed it. Next, can I deny access to requesters like payers and others requesting direct EMR access due to security concerns or other kinds of exceptions? That was a large uptick, and I'm still seeing that. Seems to be a trend right now of payers, commercial payers, and particularly requesting direct access to EMR to do things like their normal quality, reviews and things like that, claiming that they already have access to all that data because the claims information is going to them, and so the EMR access would, expedite that process. But then you have questions whether there are security concerns and other things that would allow you to not grant access. Next is, what is the US CDI data? I'd mentioned that has version 2 has gone into effect, so I'll review where that stands. And last but not least, I'll give a slide with a couple of good resources that both ONC has good resources out there, and we have a few resources that might be able to help you as you continue to work forward. I'll start here by mentioning, because it's important, right? What is my exposure? What is your exposure out there for non-compliance? I already mentioned that the deadline came and passed on April 5th, 2021, just a few months ago. And, is there really cause for concern? What's my exposure, or should I be worried about this? I don't know if many of you probably do recall when HIPAA first was enacted. It took quite a bit of a while to get ramped up with that, with the enforcement function. So in the beginning, people weren't really concerned, or I would say did not, they didn't respond with alacrity in terms of compliance until those enforcement actions really started coming down. I suspect a similar sort of thing is going to happen here. Does that mean you can ignore this? No. Compliance deadlines are compliance deadlines. That means that you're supposed to comply. But on a practical level, here's where we stand with enforcement. First of all, we don't have a final rule for enforcement against HIEs and HINs and certified vendors of health IT. And so if that's one of the kinds of organizations you're out there, there is no final rule right now, so there is no mechanism where ONC can assess civil monetary penalties against you for non-compliance. On the healthcare provider end, we don't even have a proposed rule yet. And so the bottom line is that there really is no enforcement lever where they can enforce non-compliance yet. However, as I'll mention, and I'll show you the website, they are collecting information. They are collecting complaints. And not only that, there was the most recent FAQ on ONC's website, regarding enforcement and regarding complaints. And that FAQ encouraged anybody either to submit anonymous complaints or otherwise detailing what they're experiencing and giving those details to ONC. What is ONC going to do with those? Well, first of all, we know that they can't yet enforce or assess civil monetary penalties against you. However, they are, I suspect, collecting a lot of that information, if for no other reason, to get a snapshot of what sorts of trends are occurring in information blocking. Is there a particular type of actor that is engaging with this with frequency? For example, are there numerous complaints coming in against a particular type of actor? And so, that information will never go away, and they'll collect that. I think that, once those final enforcement rules do hit, never good to be on ONC's radar screen with those kinds of complaints lodged against you, even if they don't have any immediate impact on you. So the moral of the story is, or the recommendation going away is, just like with HIPAA, I understand that maybe it's not going to hit your pocket right now, but take care, and it's important to, continue working through understanding how this rule works. It is going to have a massive impact in general going forward and forever with regard to how information is being shared and your ability to hold back that information for any reason. So it's, in your interest to continue understanding this rule and implementing it, because it's not an easy one to implement. Okay, so enough about background and just 30,000 foot view. Let's do a real quick review and review the fact that there are only 3 types of actors that have to comply with this rule. Okay, a healthcare provider, and these are all legally defined terms. So we'll need to take a look real quick at the definitions. So if you are a healthcare provider, that means individual or organizational level, or a health information network or exchange, which is a very specific defined term, or you're a health IT developer of certified health IT. Okay. Now, are you the type of healthcare provider that needs to comply? Well, you can go to this list. They cross-reference, the rule cross-references the Public Health Service Act, and you can take a look at this list. If you're on this list, you have to comply. If you are not on this list, then you are at least not the type of healthcare provider that needs to comply with this rule. So I get the question, for example, oh wait, well, I'm a physician and physicians are on this list, or a practitioner, but I work in a social service agency, and social service agencies are not on this list. Or I work at a publicly funded or a grant-based sort of community center that's not on this list. Now what? Well, and there's been a number of questions that come up like this, and the answer is, look, the practitioner is still a provider that needs to comply with the rule. There will be some tension between if you are employed by the organization, yet you're a practitioner. And so those organizations have to work collaboratively and cooperatively with the kinds of healthcare providers and practitioners that they hire, because even if they themselves are not on the hook, the physicians and the practitioners who work there still have an independent obligation to comply with this rule. Now, there were some complaints that, were coming up. I can't remember if I read it on the ONC's blog or where this came up, but there's a number of organizations that are recognizing, hey, there's a lot that you're missing here, ONC. There's a lot of social service agencies, there's a lot of government agencies, so on and so forth, that are just simply not on the list, and hey, it's not fair. We really need these other kinds of organizations to be held to the same standard. We need the electronic health information from them just as much as we should be sharing information, and it's really limiting the full scope of the intent of this rule is for that EHI to really have that free flow. So you can see that, again, I can't remember where I read this, but I know that ONC is watching. It could have been in the preamble, but I'm pretty sure actually it was in the preamble. They are watching, they're monitoring. They've acknowledged there's a number of organizations that have a lot of data. Government agencies, social agencies, grant-based agencies being, one of the types that have that large data sets. And they acknowledge that these are excluded right now, but they're monitoring it very closely. And of course, they have reserved the right to add categories of healthcare providers or other kinds of organizations. And so, depending on how many concerns and complaints, and I've actually had a number of clients that have, not a number, but let's just say that there are some organizations who are looking to get data from other parties who are not falling within this rule, have submitted their own complaints through the portal, ONC's portal, bringing that to the federal government's attention of how this is really negatively impacting, and hopefully putting it on ONC's radar that, hey, that these organizations, this lack of sharing and this lack of having leverage against these organizations, which is what the IBR was supposed to create, is really limiting. So the second large group of organizations is health information networks and health information exchanges. And this is a very broad definition. It can be any individual or entity that determines, controls, or have the discretion to administer any requirement, policy, agreement that permits, enables, requires, or use of any technology or services for access, exchange, and use of electronic health information. It has to be between at least more than 2 unaffiliated individuals or entities, not including the HIE/HIN itself, and it has to be for treatment, payment, and healthcare operations in order to fit this definition. So The types of organizations that have questions about this, if you are a member organization, I know a number of maybe hospital associations out there have had questions as to whether they are functioning like a network or exchange. The definition is very nuanced. I have been retained to do a number of opinion letters on this for member organizations. I've had a number of collaboratives of hospitals, collaboratives of FQHCs, other kinds of organizations that act through a collaborative, and that organization in the middle that's doing certain things. The question is, are we determining, controlling, or having the discretion to administer the access, exchange, and use of EHI so that we fit this definition and we need to comply? And the answer is not always clear. You really need to, the devil's in the details, as they say. You really need to parse through the facts there. So if you are one of those types of organizations, or you're participating in a collaborative like that, this question and this definition could apply to you. And that's been something that organizations over the last few months have been revisiting, looking at more carefully, and really trying to make a determination as to whether their scope of exposure based on what the activities that they're engaged in. And the last category, which is a developer of certified health IT, this sort of speaks for itself. The only thing I want to point out here that I've gotten a question about, a few vendors who are not certified health IT vendors, they do not pursue ONC certification. And so if a vendor is not going through the ONC certification program, it does not fit this definition, and it technically does not need to comply with the IBR. What impact to organizations that are using health IT that is not certified? Well, it could put you in a little bit of a catch-22, because if you yourself are an organization like a healthcare provider that has to comply with the IBR, but your health IT vendor is not participating in the certification program for ONC, and so has no real incentive to, or requirement, more importantly, to comply with those progressive criteria for certification, which are supposed to match and support information blocking sorts of practices, then you could get to a point where you're at a disconnect between what your IT vendor is capable of doing and willing to do, and what you need to do as an actor, whether you be a healthcare provider or HIE, HIN. And so that indirectly, if you're dealing with, or you're still on a non-certified health IT platform, that could create some tensions and some, like I said, a crossroads in the near future with compliance. As I mentioned, healthcare providers are going to be subject to appropriate disincentive. As I said, no rule yet, waiting on that. Don't know when it's going to come out. I know with the administration change, there continue to be very important positions at ONC and others that have not been filled yet. Some are writing that that's likely the reason some of these rules, including HIPAA, which we're waiting on a final rule for HIPAA changes, this one as well. So it's unclear when we're going to see a rule. I can't even really venture a guess, to say by the end of the year, whatever. I mean, under normal circumstances, we should be seeing something by the end of the year, but unclear at this point. Same thing with the rule that has been. So OIG, the Office of Inspector General, that's going to be able to enforce against this. CMPs against HIEs and HINs and health IT developers. There are CMPs that can go up to $1 million on this. We have seen a proposed rule and just again waiting on that final rule. Here's the reporting website. As I said, ONC is encouraging reporting. Their recent FAQ on this subject explained that you can report anonymously, that they're collecting this information. You can take a look at the website yourself. Feel free to complain on it. Again, like I mentioned, that some of my clients has used it to identify some organizations that are currently not subject to the information blocking rule and to make their arguments or positions as to why they should. So anyway, this website is here. They are collecting information. It's very detailed information. You can see on the bottom. You can drag and drop files. They're encouraging all kinds of information to be submitted. So they are very active in trying to collect information about what's going on out there and what organizations are doing in terms of complying with the rule. Okay, so let's look at information blocking. The real takeaway here is that it is a very broad definition. So if you're sitting there trying to figure out whether something is or is not information blocking, you can basically start with the premise that it probably is. It is really anything, any practice that you could possibly engage in that is likely to interfere with the access, exchange, or use of electronic health information, unless that practice is required by law or it fits within an exception, a rule that would allow you to engage in that practice that would interfere with the exchange of access and use of electronic health information. There are two standards to review. A healthcare provider has to actually know that the practice is unreasonable and likely to interfere with access, exchange, and use of electronic health information. So the reason for this different standard, as you can see here with the health IT developer HIE, HIN, they can either know or should know. So they have a higher duty to go in and make sure and investigate and make sure that, for example, their IT is not configured in such a way that is blocking information, whereas the provider actually has to know. And one of the reasons for that distinction is that the providers in certain cases might be at the mercy of the vendor and certainly are not obligated to oversee every single setting. Yes, you know, some of the implementation would require the provider to direct their IT vendor to configure certain settings, like we'll talk later about release or not release, immediate release of lab results. But in other cases, the HIE or your IT vendor may be having certain default settings that the provider has no idea are set that way. And so to the extent that you as a provider, a healthcare provider, were not aware that your IT vendor had a certain setting that was blocking information, for example, going in release to a response, then you would not be on the hook for that, because as I had mentioned in the previous slide, you actually have to have knowledge that there was a blocking practice in place. And you don't necessarily have any affirmative duty to go out there and investigate every single IT. You can rely on your vendor, which is also on the hook, the same hook. And so, they should have an equivalence incentive to not have those sorts of practices and configurations in place that would interfere with. And so they do, because they have that additional burden of going in and making sure their configurations are not set in an impermissible way, because as you can, again, the knowledge standard here is knows or should know. So, that's different between the two types of actors. Okay, disabling patient portals, something you should be aware. Patient portals was probably one of the hottest topics, biggest topics of debate and discussion and concern and angst over the last few months in terms of data. So just a couple of things to highlight here. That ONC recognized that an information blocking practice could be, for example, even though if your EHR developer patient portal offers the capability for patients to directly transmit or request for direct transmission of their EHI to a third party through that patient portal, and you as a healthcare provider choose not to enable this capability just because you feel like you don't want to deal with it, there could be reasons where you are not able to enable the patient portal. So I do want to make that distinction. This is an example that ONC gave straight out of the preamble. And so, they do want to call out that you need to be careful when you're disabling applications or functionalities, because in some cases, if you cannot justify it, then it could be considered information blocking, because it's, if there's no good reason why you're turning off or not enabling something, it could be a practice that interferes with the exchange of electronic health information, and particularly with patients. But there could be the most common cited or the most common issue of why certain features or patient portals are disabled are because you simply cannot, the functionality currently as it is, does not support being able to provide the patient portal in a way that allows you as an organization to comply with things like privacy rules. The most common category is the whole minor parent issue. And so, one of the biggest issues is, can we create this minor portal, and how do we honor situations where a minor can come and receive healthcare services on his own or her own under state law, the most common categories being for things like prenatal care or pregnancy, STD testing, in some cases mental health, addiction services. It's all determined by state law. So in your case, that would be New York law would determine whether or not a minor could receive those services absent their parent. And now you create a challenge, because if you were holding out or providing patient portals to minors, and those minor accounts are inextricably tied to the parent's primary account, meaning that the parent has authority to see everything in the minor's account, and the minor presents for an episode of care between those ages, which are most commonly between 13 and 17, that state laws give that sort of ability for minors to come in. And the minor comes in independent and says, I don't want my parent to see this. I'm exercising my independent authority. Now, what do you do with that data? How do you filter or prevent that episode of care from being able to be accessed by the parent and to honor the minor's wishes? It's a challenge, and from what I've heard, even the most sophisticated EHR solutions, which I'm not going to name any of them, but I have not run across a solution right now that provides an ideal solution to this issue. Now, as the certification process for ONC and these EHR vendors are pushed to meet certain deadlines for certification, I suspect that some of the functionality is going to improve in these issues. But as of right now, I'll tell you, the majority of organizations are either trying to configure things and customize to be able to allow a physician to turn off an episode of care if a minor comes under a privacy exception, if you're able to customize and configure in that way, or absent the technological ability to make such configurations, they are simply disabling the minor's account ability between the ages of 13 and 17, because the reason is that they cannot they are not able to honor the privacy exceptions and the privacy laws by allowing that account to remain active. And so this would be an example that, although disabling patient portal accounts are going to be inherently suspect under ONC, here I just gave you an example of where it would most likely be permissible, because you have a privacy exception, you have privacy laws that you're unable to meet given your limitations of your EHR solutions. Okay. Another sticky issue is delaying access. Question came up whether a healthcare, or this question came up repeatedly, whether a healthcare provider has the capability to provide, if a healthcare provider has a capability to provide same-day access to EHI in a format requested by a patient or a patient's healthcare provider, but takes several days to respond. Is that delay in responding considered information blocking or impermissible interference? And this was I think everybody was talking about this issue at some point. And so finally, you can see here, ONC released a Q&A. You can see here that they say that actors, for example, healthcare providers, are expected to release test results to patients through a patient portal application programming interface as soon as the results are available to the ordering clinician. So they're asking whether actors have to do that immediately as soon as the results are available. So the response is, while the IBR does not require actors to proactively make electronic health information available. So that answered one question, because everybody was asking, do we have to push all of the EHI into patient portals now? All of it, all at once, irrespective of whether or not they're asking for it, do we have to push it all in there? And, ONC said, look, we're not requiring you to proactively make EHI information immediately available. Now, there's a caveat there that I'll circle back to towards the end of the presentation, because it's not that simple. It depends on, to some extent, depends on how you hold out your portal and what you've promised to patients. But let's just start that as a premise that ONC recognizes that it's not, this rule is not somehow triggering and requiring you. There has to be information blocking triggers when there is a request for certain electronic health information and you are not responding to that request, or you are delaying response to that request for an impermissible reason. Okay, so if there is no request, there is no information blocking. So this question of proactive pushing of EHI into the patient portal is simply it's something that just came up that's, you know, a misunderstanding. Now, question came up, does a patient who creates an account constitute a request? Well, creating a patient portal account in and of itself is not a request, unless, of course, you have promised the patient that there's going to be certain data in there. Now, because of meaningful use and MACRA and some of the other federal programs that have happened, many organizations have been pushing certain data to meet their meaningful use and other sorts of programmatic requirements into the patient portal. And so if you are holding out, hey, you know, don't come to medical records anymore, all your labs and everything, we're making that information available in your patient portal, and then the patient sets up an account. Now there's an expectation that my going to the patient portal is arguably akin to a request, because you've told the patients that that's where and how they can get their data. So again, there's that caveat with, yeah, no, you don't have to push everything in there, but you need to go back and revisit of how you're holding the portal out, what you're promising to the patients, and what your processes are for requesting. Okay, so once a request to access, so I said you don't have to proactively push it, but once a request to access or exchange the EHI is made, the actor provider must timely respond to the request, for example, for a patient for the test results, and delays or other unnecessary impediments could implicate the information blocking provisions. In practice, this could mean that a patient should be able to access EHI, such as a test result, in parallel to the availability of test results to the ordering clinician. So here we go, again, causing a lot of debate and a lot of discussion regarding, so what does that mean? So it's basically saying that once the result is ready, and you've promised the patient the result in the patient portal, and or the patient has requested it in the patient portal, one or the other, that it essentially has to be pushed up. But what about our 24-hour delays? What about our 48-hour delays, 72-hour delays? What about our procedures that we put in place where the physician has to sign off or review it first and call the patient? That all goes out the window. ONC has been fairly clear on this regard that default delays, such as a default delay of 3 days or a default delay of the clinician has to review, the ordering physician has to review it before it gets released, would implicate information blocking. And they've repeated that point. And again, it has disrupted a lot of best practices or practices that have been implemented at many organizations, but that hasn't changed. That is their position. And so, you know, results should be released. The final results should be released. So if it's good enough for the physician to review, then same would be true for the patient having the right to review. Okay, so we've done a review, talked about some, some rub points with regard to actors and information blocking. Let's take a quick review of the exceptions that would allow you to block information. So exception number one, and as you can see here, there are 8. The ones that you're going to be using the most frequently are likely going to be privacy, security, infeasibility, and content and manner, which is number 6. Content and manner only because that's in place right now and effective, as I mentioned in the first few slides, through October of next year. And so you're not obligated to respond with all the EHI, so that's going to be a common one you'll go to. Preventing harm is going to be less frequent, but that certainly will come up. Health IT performance can come up. Licensing and fees are very specific. So let's take a look at the exceptions one by one and review those, okay? Exception number 1, you can hold back or not respond or say, I'm not releasing the EHI to the requester if you need to do so in order to prevent harm. Now, remember that there has to be a reasonable belief. There has to be either a licensed professional involved in that determination, okay, or that preventing harm, that harm risk has to come from the data. So the data is corrupted, the data is bad, whatever, and if you release it, it could cause harm to the person or the party who's getting the information, and so you can claim that exception. Now, this is my attempt of trying to make sense of this exception because it is quite challenging to understand, and unfortunately it's a bit convoluted, and convoluted exceptions are unfortunate because organizations don't have time for that. They need simplicity, and they just need a 1-2 step of how to implement this thing. So and by the way, you will all have the registrants. If you're participating in today's webinar, you will all be getting a copy of this PowerPoint. And so all these things that you will see on here, you'll have that for your own resources to look back at and hopefully find as helpful guidance and helpful resource as you're implementing. So, so here is a snapshot of how the harm determination works. And you can see in the left-hand column, the first thing you would ask is, who's asking for this? And you can see in row 1, and who, depending on who is asking for the EHI, will depend on the harm standard, or how difficult it is to say, hey, we're not releasing it because it's going to harm, because there's 2 different harm standards. You can see in orange, it's the substantial harm standard, which is a slightly lower standard. And in the blue, you can see that the harm standard is endangerment of the life and physical safety of a patient or the person or another individual, which is much harder to meet, meaning that you have fewer situations where you can actually use this exception as a basis to withhold the EHI from the person who is requesting it, if it is, for example, a patient or another requester who has a legally permissible right to access, use, or exchange the information. Okay, so the first step would be to take a look at who is requesting the information. Is it a legal representative? Is it the patient or legal representative, but the EHI is referring to another person and you can't extract that, and so by exposing the EHI or delivering the EHI, you would be exposing that other person who is subsumed in that data. Is it the patient himself or herself, or is it another requester who has a legally permissible right to access, use, and exchange the information? So you just crosswalk and go across, and you can see for substantial harm, it has to be a clinician or a professional with a prior or a current or prior clinical patient-clinician relationship with the patient who has to make that determination that there's substantial harm. In the last 2 categories, that endangerment to life or physical safety can be determined by either the clinician or by the data. And we have a resource at the end of the slide. You'll see the resource. We have gone through a number of use cases, and our website, our blog, and the subscription website actually have a number of use cases and white papers that go through a number of use cases, like what happens when there's an abusive situation, what happens if somebody has suicidal tendencies, a whole bunch of use cases that we've developed over the last few months, arising from questions that are getting into how exactly to implement the standard. Okay, so here are the 2 harm standards you can take a look at. I had mentioned substantial harm is a much lower standard. It can allow for things like physical, emotional, and psychological harm, whereas the endangering life or physical safety means exactly that. If I release the EHI, this is going to cause or endanger somebody's life or physical safety, and they mean that. They don't mean some quasi-emotional, psychological. That does not meet the endangerment or life or physical safety, the blue standard with regard to how this is applied. Okay. With regard to lab results, this issue came up again. There was many physicians, clinicians, commentators who mentioned, hey, we really need to delay these lab results because this person just got diagnosed with cancer, or the lab result just diagnosed this person with, a hereditary disease that, the clinician needs to buffer that and explain that. And the patient who's asking for a copy of their lab results could be devastated and could potentially harm themselves if they get a lab result without some context. And so it's our process to allow the clinician to explain these lab results and act as a buffer, rightfully so, in that clinician-physician relationship. And ONC said no. There were many comments that were submitted along these lines of this argumentation of why it's a good idea to delay lab results. And essentially they said we have found no evidence in the comments or otherwise that routinely delaying lab results to patients who are requesting it substantially reduces the danger to life or physical safety of the patient. Okay, so unless there's a law that prohibits it, you need to disclose that and not delay that result to the patient. Now, the exception is, and how many of my clients have sort of gotten around this is, ONC did acknowledge that it is the patient's choice. Okay, so you can't make a decision for them. This is the default, we're proceeding forward, but you can, of course, honor the patient's request and preference for delaying lab results. So what do you need to do? Well, when you order the lab result, when you have that initial, your clinicians or the patient arrives, the lab is ordered, you ask them whether or not they want to have those labs immediately or whether they want to have those lab results relayed to them by the clinician. If the patient confirms or specifies that they would like the physician to relay those lab results to them, then you follow the patient's wishes. No longer an IBR issue. It's just those, the baseline of not having, just outright as a baseline delaying things is what ONC does not like. Okay. Exception number 2, privacy. There are 4 sub-exceptions. Precondition not satisfied. The first sub-exception is going to be the most frequent one that you're going to probably go to. In a nutshell, essentially what this means is that if a state or federal law requires you to satisfy something before you release it, the most common issue is going to be consent, and you don't have that proper consent, and you have a third party requesting the information, and you can't release it to that third party because state law requires you to have a consent first, to obtain consent first, you can rely on this exception and not release it based on that precondition not satisfied. The only change here is that the rule requires you to make an affirmative effort to get something like a consent and not just point to that as a basis upon denying the request. There's a couple of other sub-exceptions. Health IT developer not covered by HIPAA, denial of requests for their EHI that's consistent with the HIPAA access rule. So the 2 subsections, A1 and A2, carve out 2 specific exceptions where you can deny based on privacy rule, deny access, and then respecting an individual's request to not share information with third parties. And so confidentiality requests, please don't share it with my health plan, please don't share it with my spouse, don't share it with my kids, whatever, would be a privacy exception that you can deny. Security exception, there's concerns with security. If you do have a practice, it has to be directly related to the issue, tailored to specific security risks, and you have to apply it in a consistent and non-discriminatory manner. What they don't want here, and what I've been dealing with a couple of questions coming up again over the last few months is, yay, we like that provider group because they refer a lot to us, but we don't really like that provider group because they refer to another hospital. So we're going to take that, we're going to tell that provider group that, they got to go through, we can give them access, just sign this one form, but that provider group that we don't like, we're going to make them go through the security ringer, fill out all these exceptions, put all these restrictions on them, all this sort of thing, even though the 2 groups are essentially the same and there are no different security risks that are inherent to one group or the other group. So that's where you need to watch out for the security exception and how you're implementing it, because ONC places a lot of emphasis on making sure that you're applying those security measures and those security interventions really tailored to the security risk and not being applied differently to different groups unless there's a justification for doing so. Exception number 4, somebody asked for EHI, it's infeasible. I can't give it to you. It's not possible. Number 1, there's an uncontrollable event. This is your force majeure. There's a hurricane. There's this, whatever, this, that, and the other case. Segmentation I cannot segment out information that I can give to you from information that I can't give to you. The IT does not support me just giving you the information that you've asked for, and so I have a segmentation issue, and so the IT doesn't support it, and so you can claim infeasibility under that, and infeasibility under circumstances. There's actually an entire sort of checklist you need to go through to see if you can claim infeasibility under the circumstances. We actually have a tool for that. There's a documentation required, but again, just know it's there. Health IT performance sort of is what it suggests it is. You might have downtime because of maintenance improvements, there's level performance issues, security related practices. So if you have health IT performance issues, you can look to this exception potentially to deny a request. Okay, this one, content and manner. I had mentioned that, that through October of next year, you are only required to respond with a subset of EHI, referred to as the US CDI standard, okay? And after that date, you have to respond to all. So as crazy as this sort of might look in implementation, if you get a request for EHI, say entire record, you are only required to respond to that request with the US CDI subset. You would not be in violation of the rule if you hold back certain information that does not fall within the US CDI subset. So that's how the content exception applies there. There's also the manner exception that if you cannot fulfill the request in a certain way, that you can fulfill it in an alternate manner. And so again, there is a documentation requirement that goes there. Again, something to bear in mind with that. Here's a copy of the US CDI core data set. This was version 1. You can go to the website here to take a look at what that looks like. We are now, as of July, on version 2. You can see there's been a number of changes and additions to that subset. I've highlighted some of these for you, and you can take a look there. One of the, excuse me, had a technical issue there. One of the biggest changes or the biggest additions to the version 2 is that they've added in a number of places social determinants of health. You can see that listed as SDOH goals. So take a look. Again, I provided you with the hyperlink there and understand what is the entire scope of data that you're required to comply with at least through October of next year. Okay, excuse me, fees. The bottom line here is if you are charging fees for any reason in exchange or in connection with a request for EHI, you have to make sure that it fits within this exception. Fees or imposing any kind of fees as a condition to the sharing of electronic health information could be considered an interference unless there is a objective and verifiable criteria for the fees. They have to be reasonably related to the costs and not based on competitor, potential competitor, or whether the EHI will be used in a way that facilitates competition. So the bottom line is that if there are fees involved in exchange for EHI being shared, you need to take a look and make sure that those fees are fitting within this exception. So from a practical standpoint, how I've seen organizations implementing this is that their contracting department takes care of fees, that they have a little cheat sheet understanding, hey, if there's fees involved here and there's exchange of electronic health information, that may need to get routed to legal as a final review to make sure that those fees that are part of that contract comply with the IBR exception. Here's an FAQ on the topic that essentially reiterates what I just said. Contractual fees for the export of electronic health information using technology that's not certified. Are those contractual fees enforceable if the fees were agreed to prior? And the answer is yes. So your past contracts can get implicated by this as well. I have always said, gone through a number of organizations reviewing their contracts and agreements and making sure that retroactively that those are updated to make sure that they comply with the standards that are currently in effect. And last but not least is the licensing exception, similar to the fees exception. If you have a contract, this probably would most likely Start with your contracting department. Any agreements where there's a licensing arrangement in connection with the access or exchange of electronic health information should probably get routed and sort of blessed by legal to make sure that it is fitting within this exception and meeting the criteria of this exception. Otherwise, an impermissible or a licensing arrangement that doesn't meet the criteria of this exception could potentially implicate the IBR. So what resources are out there? You can take a look at the ONC, Office of National Coordinator has a resource page. I've provided the hyperlink there for you. You can see that their resource page has things like fact sheets. They do have webinars that they've posted up there. There's press, there's blog posts. They actually have the final rules posted there. And probably the most frequented resource is the information blocking rules. They are, somewhat regularly posting FAQs as they get questions from people and actors out there. They, in time, if they get the same question repeatedly, they will eventually post an FAQ on it and give some further guidance. And you can see if you go on there later that, as recently as July, they've posted some FAQs, some more recent FAQs on there. So there's the hyperlink to the FAQs. You can take a look at our blog. We have a blog called Legal HIE. We often post it, and that's free. You just subscribe to it, give us your email, and you'll get notified when we have a new article posted. We keep on top of this stuff, my partner and I. This is an area that we, specialize in, if you will. And we're always looking for the the most recent hot topics and issue topics, and we're writing on them on the blog. Additionally, we have a compliance library that is a supplement to that. That piece is not for free, but the blog articles are, and there's a lot of information in the blog articles. Compliance library has things I had mentioned, a white paper, like for patient portals. We've developed things like use cases. It has things like a hierarchy, like an algorithmic sort of Q&A, a sort of algorithmic question and response, yes, no, to follow, to see if you fit within an exception. So we have a lot of, really neat tools on there. So I said I was going to, if you do subscribe, or if you do check out our website, I provided a discount code for you for today to get a discount of that. I did say I was going to leave 5 minutes, but we have about 3. So I can do what I can. If there are any questions, I will take those questions and do my best to respond before the end of the hour. Nick, I don't know if you saw any coming through.
No questions came through.
Okay. Well, I always say that after after a presentation, if anybody has questions that they'd like to submit, I don't mean to put the onus on the New York chapter, but if you out there, if anybody has questions, I always like to provide as a courtesy. Happy to take those questions from New York chapter if you want to submit them to the chapter, and I can do a follow-up sort of my own FAQ sheet afterwards and as an additional resource to the website. So feel free, if you couldn't think of the questions while we were going through the presentation afterwards, feel free to submit those and I'll do my best to respond to them. With that, I thank the chapter again for inviting me to present today.
Helen, thank you very much. It was terrific. I also just would like to mention that you were just named the best lawyer of the year for healthcare law in Princeton, and congratulations on that. And we're, again, very pleased to have you. I would also suggest if anybody has some questions, you can direct them towards me and I can relay them to Helen. So with that, I'd like to say thank you. And for anybody that is able to make the call today, look for our next meetings coming up next month, and in October and November. We've got a full slate of new events, and we're more than willing to be able to continue our education. Helen, again, thank you very much. Nick, I think we're in conclusion. Thanks, everybody.